I'd like to welcome you to this webinar. We have some guests online today to give some different perspectives from two very different areas in the world. I will probably give a little update first, and then I will hand over to our guests. We have with us today Professor Shabir Musa, who's the president of Wonka Africa and very involved in the COVID-19 response in South Africa. We also have with us Dr. Anne Wensing, who is a virologist at the University Medical Center in Utrecht in the Netherlands, and also a professor at the University of and I'll try and say this correctly, Witwatersrand in Johannesburg, South Africa. Along with Dr. Anne Wensing, we have Dr. Pauline Ellerboek, an infectious disease specialist, also from the University Medical Center in Utrecht, and a member of the Dutch National Outbreak Medical Team. So we're very privileged to have these folks on the line with us today to share their experiences. As a quick start, before we hand over to the important part of the session, I'm going to share my screen. And I will give a very quick update from WHO just on the EPI, where we are at the moment. But I don't want to take too much time because I want to leave enough of the presentation time to our guests. So just very quickly from our side, we now know that we're well over 750,000 cases globally, and 203 countries and areas are affected. Unfortunately, over 33,000 deaths have been reported to date, and the countries with the highest number of cumulative cases, and this is as of today, is the United States of America, Italy, China, Spain, Germany, the Islamic Republic of Iran, France, the United Kingdom, Switzerland, and the Netherlands. For WHO, our major health sector concerns at the moment is, of course, the increasing demand on the health systems and on health workers globally, potential shortages of supplies for managing COVID-19, and these potential shortages are due, of course, to the increasing global demand, and also due to insecure supply chains because of travel and transport restrictions. We've also seen some countries implementing restrictions on export of PPE, and of course the inappropriate and sometimes overuse of PPE outside of the health sector. One of the other concerns that we really are facing at the moment is the maintenance of essential health services in the light of the growing pandemic. And just on this last point, I just wanted to draw people's attention to two new sets of guidance that have recently been released by WHO. The one is on maintaining essential health services during the COVID-19 pandemic, and then a manual on how to set up and manage treatment centers for COVID-19. And that's all I'm going to say for now. I will stop sharing my screen. And I am going to hand over, first of all, to Professor Musa from South Africa. Professor Musa, would you like to take the floor? And if you have some slides, you can share those too. You are on mute at the moment, so we don't hear you yet.
Sorry about that. My name is Shabir Musa. I'm a family physician in Johannesburg. I'm working in Soweto in the clinics there. Just came back and I was hoping to actually stick in my slide a picture from what is going on in Johannesburg. Let me perhaps just put it on slide and you can then see. The situation in South Africa, and I'm going to go through something which I will repeat on Friday in a seminar series with WHO that is going to look at different African countries. And we're starting with South Africa, so apologies if you see it on Friday, similar things. Essentially, Africa has got a relatively low number of COVID-19 cases, and this is as of today. And as you can see, as a population of 1.2 billion, that looks pretty decent. The problem is that when it sweeps, it may not, it may leave ravage behind. And I think that one of our challenges is to try and reflect on the fact that Africa has got a whole lot of other problems that Europe does not have, like lots of multi-morbidity, immunocompromised people, famine, people with immune status that's poor because of their nutritional condition and poverty, etc. So I think we have a lot of challenges, including crowding. So I think this is a important problem that we need to get ahead of, and I think that's the lesson we want to have, but not only South Africa, but Africa. I think the sort of trajectory in South Africa as being a hotspot in Africa is that we've got about 1,300 cases, which is about a quarter of the number of cases overall in Africa. We are very fortunate, in fact, I did this a few days ago, that by the weekend we did not get to that 1,567 based on the trajectory of the first 2-3 weeks. I think that I'll talk a bit about how the response has been, but I think that given the trajectory that was over the last 2, 3, 4 weeks, we would have within 2 weeks more 60,000 cases of patients identified as positive. And I think that trajectory would land up ballooning very badly if we didn't get a handle on this. And another thing worth noting in South Africa is that we really had a very low death rate somehow. And we do have about 5 to 7 patients in ICU. I didn't get a chance to look at what's happening today. But I think that there is a relatively more low morbidity from the number of cases that we've seen as positive. I think that what we face as a real problem, as I said, is that we have challenges in our healthcare system. And we've got, if we estimate 100,000 cases, we're looking at admissions of 20,000 beds, and ICU or even CCU care patients needing about 5,000. Yet in the country, we've got a total of 7,200. And actually what is available, considering the other patients that are around, is half of them. So we really have a challenge and in terms of bed capacity. But the real challenge is that how do we actually manage, given this low bed capacity in primary care, with a whole range of issues, not only with being able to manage patients, but we will look at case and contact management in the community. Just a little aside as well to say that, our last influenza season, we had 47,000 people with severe respiratory illness. And if you're looking at, the cases of upper respiratory tract infection, a quarter of them were influenza. And that's literally bread and butter. So you could almost say that's, 25% of our population. And we had only 0.1% deaths with about twice that number in admission. COVID-19 is 30 times that amount. So you can imagine how big a burden it's going to be for us going forward, especially with the risk groups that we have. So our initial response in South Africa has been, our National Institute for Clinical Disease has been a very adept at preparing government for it. There's been airport screening, which I found a little limited, and that's been going on 6 weeks before the 3rd of March. It's been literally since January that they've been screening for temperatures at the airports and trying to manage patients in. But the difficulty is that doesn't pick up asymptomatic carriers. So that has slipped through the country. And as soon as we started getting from the 3rd of March, the first case, they started the contract tracing. And by the 15th of March, with not more than 100, the government decided that they will, in fact, institute social distancing, limiting large gatherings of more than 100. They actually restricted borders, closed schools, discouraged public travel, and then restricted visits to prisons and looked at malls and others. But I think the key problem that they faced was the economic impact in the setting where we are with high unemployment rates and a real risky scenario with shutting down the country. Of course, within a week after that, the government, considering the trajectory we had of 30% per day, per week, we had to shut down the entire country. And I think in terms of critics, in the country, that's been a welcome, speedy action by government and effectively getting ahead of others that are dithering globally. Whether that's enough to nip this in the bud is a question. Effectively, the entire all businesses are closed except essential care, and people are forbidden from going around except for banking and food and other things. And I think that you can see that the emphasis is on testing and tracking. A key, the president actually announced last night that there will be a national process of tracking cases and actually going through the entire community looking for cases and getting them to be checked, tested, and then their contacts traced. So these are other things that speak more to the intervention, economic interventions, and especially important is the question of unemployment and how people manage that, as well as compensation, particularly for healthcare workers. The challenge has been how to manage healthcare workers. And I think particularly in primary care where I work, hospitals which are kind of designated are usually well capacitated reasonably at this point in time. But the train smashes in primary care. So about 2 to 3 weeks ago in Johannesburg, which is really, and in Soweto where I work is the ring space of Johannesburg, which is really the smallest bit of the middle of Gauteng, which is the smallest province in the country, but the largest in terms of economy as well as population. So it's the largest population province in the entire country. So it's a hotspot in itself, right down to the place I work, which is Soweto. I think the approach that we looked at in trying to prevent at primary care level was to say, and we had a public health approach, in these district with the NICD in chasing contacts, cases and contacts. But we said from a facility across the entire primary care setting, can we get an action plan at a facility level, reaching out to the community, and how can sub-districts support them? So in essence, we said in the community, the facility manager itself needed to really step out, ensure that community of workers were deployed to actually educate people. And this plan was only signed literally about 10 days or a week ago. So we've actually passed some of these plans in timelines. We tried to get the community involved in terms of our processes and then really decide on a clear message. And that was a challenge because the national message spoke very generically and it did not speak to how people should respond to when I'm sick, what do I do? And they weren't clear about it, saying things like go to your nearest doctor, when in fact there isn't that capacity in the public service. So there are many mixed messages as to what people do, if they were sick. So we actually spent time thinking that through, particularly for us to encourage people to stay at home with minor illnesses and only come to the clinic when they need. Then at the clinic itself, we tried to create a screening area at the gate, a triage space at the gate, because we found, people just milling around. Everyone was cough and cold was just going around wherever they needed to. And then we said at the gate with cleaning and PPE for the staff at the gate. We actually said, let's get sprays, sanitize for hand. And then we thought we'd give patients our coughing masks, but we realized we don't have enough. So we actually said, patients, just cover your mouth, and we're struggling with that idea. But nonetheless, that's what we thought. We then said, let's have a designated area as a chest clinic. And that's been a challenge. I come from a community health center where I work. And what they put up is literally a tent from the, from a undertaker in the vicinity, and it's just a tent on grass, and there are people there, and at the moment it's not as critical where just patients with coughs are being managed, but it's just not the kind of clinically suitable space to manage patients who are ill. We also said that there needs to be very strong protection of staff and the management of that chest clinic, so anyone who works in that area needs to actually manage that well, and we have to decide what would staff get in that space, plus what we would be deciding in the isolation space, which we said would be much more better equipped than, and that was next to the chest clinic. And we had to stress to the managers how to manage the overall facility, ensuring this space is protected, but elsewhere, how do we get people being encouraged to space, wash hands, etc., and getting staff, assuaged about this problem and informed and debriefed. And then the last thing was just for us to ensure that what we put out in a plan was to be implemented, that staff were available, because we had challenges with having to run this separate space for the day and then increasingly as a problem for the night, when patients were popping up in the middle of the evening or even at 4 to 6 when these cases do surge. We have basic problems, and we have that even now at PPE. And as I mentioned, managing these emergencies. And also, how do we manage referrals, in that setting when patients come in and we had to set our clinical protocols using the guidelines available, but thinking through what we have available. We also were considering social quarantine sites. It's not yet a need, but it's on the cards. And then looking at how do we support this process at a district level. I must be honest, in the South African context, it's already very challenged, even with this kind of limited response. Should we have more cases, more deaths? I can't imagine what's going to happen. Thank you.
Thank you very much, Professor Shabir, for sharing your experiences. I'm sure that there will be questions for you. I'd like to invite participants to please use the question and answer facility on the Zoom chat, and we will try and field those questions through to Professor Shabir at the end. We're going to go straight away now, I think, into the next presentation. So I would like to invite Dr. Anne and Dr. Pauline to please introduce themselves again, and I will share your presentation from my screen. Over to you.
Hello, this is Annemarie Wensing and Paulina Ellebroek. Thank you for giving the opportunity to share our experience. Can you hear us well?
We can hear you very
louder?
well. No, this is perfect. Thank you.
Next slide, please. We are more presenting our experience at the hospital level compared to the public health response we just heard. And the Netherlands is a country with 17 million people. We are among the highly densilated countries in the world. If you look at countries with over 1 million people living there, we are among the top 10 of dense countries. And actually, end of February, early March, people all go skiing, especially in Italy. And after skiing, actually the Dutch Carnival, which is like a religious party for a couple of days, like the Brazilian Carnival, which is actually mainly done in the south of the Netherlands. And actually most of the spots that you can see here on our map of the Dutch country are actually in those areas where people went after skiing into the carnival. So currently we have 11,750 confirmed cases, and almost 4,000 of these are admitted. Of course, we have many more cases in the countries, but we stopped testing in the population because it was just not doable anymore. Also because of lack of PPE, protective equipment for the healthcare workers who had to go there. We have currently over 1,000 people at the ICU units in the hospitals, and almost 1,000 people reported death with COVID infection. Most of these deaths are actually older people and people with lots of comorbidity. So what we have done at the public health response is that March 9, actually social distancing was pointed out by the government, and people have to stay home as much as possible, keep distance, and people had to work home as much as possible, and bars and restaurants and public places were closed. And a week later, on March 16, also primary and secondary schools were closed, and universities as well. So, but there are actually digital programs, and most of the children still follow school. And these measures, which are now, the first one was 3 weeks ago, and the second one with closing the school 2 weeks ago, seem to be effective. We see the growth of the epidemic slow down. And at the end of the week, we will for surely know whether these measures are effective. And this is called a so-called intelligent lockdown. So it's not a full lockdown. Next slide, please.
So I will take you through the preparation of our hospital. So we have defined the way we manage a crisis many years ago. So we have a defined crisis management organization, which we then filled in for this corona epidemic. So in the top, you can see that our hospital is formalized at the level of the board of directors by the crisis governance team, which is mainly responsible for the continuity of care and process in the entire hospital. And they lead the crisis coordination team, which is called the Corona Coordination Team. And they steer a full set of response teams, which you can see in the lower, which are mainly operational teams. So on the left side, you can see the response team, outbreak management team, which is primarily responsible for the medical process around the patient. So the admission process, the treating teams, the diagnostics and isolation procedures, and the treatment protocol. And then you can see at the right part, all other response teams, which are quite a lot, but that's because we are a university teaching hospital. So we had to address all those subjects like education and research. There's a communication team, of course, a human resource team, facility management team, a medical microbiology team, and a team that runs operations and capacity. So all these teams work together, and we have standard times at which we confer with each other 2 or 3 times in the week. Next slide, please. So we defined 3 upscaling phases in our hospital. And phase 1 would be where just a limited number of patients would present to our hospital. We are ahead of this phase now, but in this phase, we admit patients in the regular care flow in separate isolation rooms, and we wouldn't notice anything that would be done in the other things that we do. So there would be no effects on the regular care processes. At this time, we are in phase 2, where more patients are admitted, and we experience that this has effects on capacity, especially the ICU ward, which has been scaled up long before we needed to upscale the wards. So in this phase, COVID-19 proven patients are taken care of in cohorts. So they would be taken care of multiple patients in one room, also in the ICU. And we already downscaled research and all types of education, but also the regular OR program for non-critical care. So in phase 3, we're not in phase 3 now. The number of patients would exceed the regular capacity strongly, and then our whole hospital would be about COVID-19, and we would have to downscale regular processes largely and only upheld the urgent care, and we would have to create multiple separate wards. Next slide, please. So you don't have to read this scheme, but in this scheme we depicted all the subjects that would have to be addressed in all 3 phases, phase or category 1, 2, or 3. So you can see in the middle at the left that for each phase we decided what type of isolation would be proper. Would it be in separate rooms or on wards, in cohorts? The policy about antiviral drugs, also the admission policy, which staff would be deployed in which phase. So, for example, in the first phase, we can use the regular staff, but in the second phase, now already, we're deploying doctors and nurses from other departments. And on the lower, you can see the impact on the hospital in each phase. So we use this large screen to write out and all the aspects that would have to be addressed. So in order to prepare for the next phase. Next, please. So our clinical capacity. So in the Netherlands, there are about 1,000 ICU beds operational normally. This is not a lot on 17 million inhabitants, but it's based on the general good health of our population. So not much more beds would be needed in a normal situation. And we are foreseeing that in this corona epidemic, we will have to at least double the amount of beds. And if the epidemic is not slowing down, even triple or quadruple this amount of beds. So at this point, at this time, about 1,200 beds are used. So the ICU had to upscale already 2 weeks ago. And they did this by, on the left side, downscaling regular surgery and therefore deploying operation room personnel and machinery, use of stocks, and in the next phase, we would foresee collaboration with the military. So the UMC Utrecht normally has 24 beds. You can see this in the bottom, and they upscaled to 36 1.5 weeks ago. And this week they upscaled by using the recovery unit of the theater, which can have 20 patients in cohort. After that, we would have another option of upscaling with another 11 beds. So at this time, we have 57 beds open for COVID patients. And then the general wards. The general wards, at this time, we already created 2 COVID units with cohort facilities. And we will foresee to open the 3rd one this week. The expansion has been limited mainly by personnel. It takes some time to use personnel from other departments, to train them, to make them feel comfortable. And also we had to reduce regular care to do so. Next slide, please. So here you can see what happens if a COVID-19 positive patient is displaced from another hospital to our hospital, or to patients on the right side, which present at the ER, an outpatient department, or another hospital department, which the latter have been downscaled already. So if a patient has been COVID positive tested in another hospital, this patient would be transferred directly to our cohort. On the other hand, patients who present to the ER or other departments and have signs of air tract infection will be tested not only for COVID-2019, but also still for other viruses, respiratory viruses like influenza. And they will be isolated and PPE will be used until results are known. And other patients who have no signs of air tract infection, so all patients are asked if they have signs. So if they have no signs, they can follow the regular admission and care path. Next slide, please. So for the clinical management, we developed standard protocols for viral testing, other chemistry tests, radiology. We developed standard charts, especially helpful for doctors or nurses who are not used to working with, in fact, patients with an infection. And there are protocols for ICU care, resuscitation and such. we have developed discharge criteria, and there's a medical treatment protocol. Next, please.
Yeah, we also, for infection control, we made particular charts to be used for the healthcare workers. So not only what they had to wear, but also how you dress and undress. And I think these are particularly handy, especially if you have healthcare workers who are normally not working at departments with infectious diseases. And they're trained by peer-to-peers, and they can follow these charts. And in that way, you can make it very quiet, and people stay calm, and that helps a lot in feeling themselves safe. Next slide, please. So what we also have done on the wards is actually the most of the pressure, because in the Netherlands, people only go to an IC unit if we know that they have a chance to come out alive. So that's already normally the way how we approach the IC unit. So many people have multiple comorbidity, and from which we know if we will go to full respiration, they will not survive. They are actually taken care of in the cohorts. So it's a pretty heavy department also for the nurses who are taking care of those people. And what we have done, several things to really support them. So like wireless monitoring with biosensors. And for each patient, we have continuously pulse oximetry, blood pressure, and temperature. So that takes a lot of time away from the nurses, and they can focus on other things. Also outside the room, they can very well monitor these patients on the wards, which really gives them time also to give supportive care in more psychologically and other things, and not only doing the medical things. Next slide. What we have also done is enlarge our capacity for testing. So we're doing currently a PCR with a platform which can run 4 times a day with 100 samples. And we also are working on rapid testing, which is not yet available because we have a problem with supply of kits for rapid testing. So apart from testing patients, we also test healthcare workers with clinical symptoms, because our hospital is not in the heart of the epidemic, and about 10% of our patients, of our healthcare workers with complaints, are infected, and we try to keep them away from the hospital. And they're tested, they come with a car to the parking garage of the hospital, and then they are sampled from the car, so they don't step out. And in this way, we can sample up to 228 healthcare workers a day. And this has been really efficient. Now we have some more space because everybody who has complaints has been tested and are done real time. So we have opened up these facilities also for other healthcare organizations, primary care and ambulances. So all of these healthcare workers can come to our garage and be tested, and the results are sent by email to either their occupational physician who takes care of them, and also to the authority, so they can take acknowledgement of how many healthcare workers are actually positive. Next slide, please. What we have also done is in collaboration with another huge hospital in Amsterdam, the OLVG. We have developed an app for patients who are at home, and they can actually self-monitor their symptoms. And they can use this app daily to bring in enter their symptoms in this app. And then actually they even get an automatic response if the symptoms are really mild. But if they have more serious symptoms, there's actually a call center that, and it's staffed by medical students and interns who actually then follow up these people and refer them to the GP. And this has been really highly used. You can see after we opened up, 8,000 users in only 3 days. So this actually helps a lot of people in the community, because there's a lot of uncertainty, because we do currently not test in the population anymore. Next slide. We've also thought a lot about the welfare of our hospital employees, because this is going to be a long-term thing. And we thought everybody wanted to work really hard in the beginning, but we thought it's really important that people, stay up there and be active and smart for the whole time. So in that way, we made crisis schedules with adequate resting time. And for those who are working on the wards, food supply, and for all employees, free parking, so they don't have to worry about those things. People who don't have to be on the floor actually all facilitated remote working at home, and that works really well. And also we're offering psychological social care for people who have difficulty either in their own environment with people getting ill, or maybe have deceased people around them, but also related to the work they are involved in at the hospital. And we have set up effective communication. Every day they get an email, what's going on in the hospital, which measures are taken, and asking them for their flexibility, because everything is different from normal. We've also put more people on the floor by task shifting. For instance, researchers are doing diagnostic testing. Researchers are helping with the drive-through for the testing. So in that way, we have more people helping, and people can still have their rest. We've also allowed a rapid recruitment with human resources, so we can, healthcare workers that were actually nowadays involved in other jobs are actually actively being brought back to the hospitals to help, and people really volunteering to do this. We've also set up peer-to-peer training, because people actually often doing work which is a little bit outside their comfort zone, and we don't have a lot of time for formal trainings, but peer-to-peer to ensure everybody's really qualified for what they do. And we've also already set up a response team for after the epidemic to really think about what are people needed to go back into normal life in a later phase. Next slide, please. So finally, we'd like to really acknowledge the crisis coordination team and the board of the University Medical Center in our hospital. Also the employees, because we really ask a lot for people's flexibility. And we see a lot of can-do mentality, but it's really important that you ask people to do their job and not to complain too much. And we ask everybody, please reflect on what can be done better, but in a very positive way. And that's something we started from day one on. And that works really well. So people can give suggestions, but meanwhile, they do the job that they're asked to do. Also, we have a lot of support from patients who are actually ill themselves, but are willingness to adapt. Sometimes outpatient care visits are brought into, are stopped, but they're called by their physicians. And we see that people are really patient and happy they're still be taken care of, although it's in a different way. And furthermore, we have a lot of volunteers and citizens who bring food or make happy things to the people that are in the hospital or are working here to support us, which is really worthwhile and also shows a lot of solidarity throughout the country. That's really heartwarming. So thank you. That's what we wanted to share with you.
Thank you so much for taking the time to share your experiences and the presentation with us. I'm going to open up very briefly to my panelists who are on the call to see if they have any questions. I know that we have from WHO, we have Catherine Kane, who works for the Health Workforce Department. We have Ivan Ivanov, who works for Occupational Health. We have Judith Van Holten, who's also working in the EPI-WIN team, and Rosamund Lewis, one of our chief experts on the COVID, and in addition to Dr. Sylvie Briand, who is the director of the department that we all work in. So perhaps Sylvie, would you like to make some comments?
Hi.
Hi, we hear you now.
Okay, thanks a lot, Sarah. No, I have no comments. I mean, it's so interesting and fantastic to see how the adaptation in each setting and how people can cope with this really new situation. And so I think it's really very good for us to see how things can be implemented at country level, and it's very useful to inform also our guidance and to also provide more recommendation, useful recommendation and practical ones to other countries. Over.
Thank you, Sylvie. Are there any other of the panelists who would like to make some comments? Rosamund.
Sarah, yeah, Rosamund here. I just wanted to ask a question, actually. There's so much. Sorry, I was going to start the video, but it's off. There's so much in both the presentations, and at the risk of going out in left field a little bit, I would like to hear from both of you how you are supporting the communities to support routine services such as immunization, failing which we will have outbreaks of other diseases to cope with at the same time.
Thanks, Rosamund. Professor Shabir, would you like to answer first?
Yeah, sure. I think the panic that set into the public service has been such that that every bit of our energy is going into this. I suppose the risk you talk about other disease immunization. That obviously if it persists, if it goes on for longer than 2 or 3 months of this kind of focus, we are going to run into trouble. We also have, I think all care, routine care is being reviewed. We've begun to say to patients, you know what, come back in 6 months, here's a repeat, and non-urgent or elective type of referrals are being shifted out. So I think these are going to perhaps come back to bite us if we don't take care. Fortunately, I think there's a bit of a challenge in the African setting where lots of the care is inappropriate. In other words, patients who are really sick in the community are poorly screened and don't get the care, and then people come to the clinic for those things that are really minor. So coughs and sniffles are one of those things that we see lots of. And that's why we set up at the gate this triage, and in fact hand out literally a few drugs like Panado, Allergex, dealt with by a nurse clinician who reviews the patient very quickly. But if there's anything she feels not comfortable with, then is referred to the chest clinic. So I think there's a very different way of working, which I think can create problems in the long term. But I think at the moment, with these numbers jumping up day by day, it's created a sense of panic in everyone.
Thank you very much. Anne or Pauline, would you like to respond?
Yeah, I think we are currently, after the first handling of the crisis, are now really in discussion about continuation of care, and that's also preventive care. We have not downscaled all our care, and I think it's a little bit of a different situation from South Africa, because the Netherlands has a very strong first line, what we call first line care. So everybody in the Netherlands has a family doctor. And so we in the hospital don't have people walking in with minor complaints. So that's totally different from many other countries, I think. But definitely it's important that preventive care should continue. And I think with specific measures, that's also possible. You can do still vaccination with social distancing. There's a lot, that's able to be done. And I think these are postponed, but will not be postponed for months. Is that answering your question?
Thank you. Yes, I'm now going to hand over to Catherine Kane. Catherine, I think you had some comments or a question.
Hi, thank you, Sarah. That discussion is actually quite important. WHO did release guidance last week with regard to maintaining essential health services during COVID-19, and it's understood that that is going to vary by national context and the resources that were already available. However, one of the greatest tragedies could be from this outbreak, the secondary deaths that happen because people aren't receiving the essential services that they need. So I can say that WHO and its regional and country offices are eager to work with stakeholders on how to maintain those services concurrently and safely. On a next point, it was really interesting to see the different approaches and important to see how those are being adapted to context. Dr. Musa, I was really thrilled to see the notes on community health workers, because while we focus a lot on the needs of hospitals, we also need to remember that the community needs to have services like health promotion, like hand hygiene, like contact tracing, coming to them from sources that they trust and also in a safe way. So I appreciated your comments with regard to that. And in fact, the comments also from the Netherlands regarding the app that you have for individuals to self-monitor, look for warning signs, and stay home in isolation, which, as we know, is going to vary very much significantly by context, with some countries looking at whether or not they need to open up congregate care facilities for people with mild symptoms. I would like to highlight that in the coming week, we will be releasing a health worker modeling tool to support response to COVID specifically, as well as a piece of guidance on essential health services, including health workforce issues during COVID. So we'll be sharing that with the group as soon as it's available. And lastly, one of the most exciting things that we've got on the horizon now is a rapid scale up of the WHO Academy, which was scheduled to launch next year, but we should be launching an app later this week to consolidate a lot of the information and guidance for health workers, but more specifically with a view within the next 2 weeks to opening virtual workshops and classrooms to enable just-in-time delivery of critical training, workshops, and support on issues that were already highlighted by survey respondents. We had a survey, and within 4 days, we had over 4,000 respondents globally who were prioritizing case management, infection prevention and control, and use of personal protective equipment. I was interested to see the Netherlands diagram on that. So we will be launching progressively the WHO Academy, which will be available to and targeted towards health workers and their organizations to rapidly scale up the response necessary for this outbreak. Thank you for that opportunity, and we look forward to this continued dialogue, which is incredibly valuable for us in creating the right sorts of support.
Thank you, Catherine. Ivan, over to you. Please introduce yourself to the group again.
Hello, I'm Ivan Ivanov, and I'm the team leader of the WHO program on occupational and workplace health, and I work with several groups under the COVID response. My message to this audience is that the infections among health workers and the damage that is caused by the response on health workers' physical and mental health and well-being have multiple causes, and all of them are related. One is the exposure to the virus through patients, through suspected cases, through surfaces in healthcare facilities, but also outside of healthcare facilities during the commuting to work, at home. So measures for prevention of the transmission of the virus is important. There is also, we have data that there is a transmission of the virus between health workers and healthcare facilities. So that should emphasize also the measures for prevention of this transmission. For example, observing also physical distancing among healthcare workers when they are not in PPE, when they, for example, take a rest break or socialize. So in addition to that, there is a lot of evidence already coming on fatigue, burnout, even suicides among health workers as a result of the enormous stress, workload, and compassionate fatigue during the outbreak. Certainly, it is necessary to adapt the working time to the crisis situation. And when adapting the working time, it is also important to to have shifts that are no longer than 10 hours, in exceptional situations, 12 hours, but with sufficient time of duty to sleep to at least 10 hours to allow for 7-8 hours of sleep. It is also important to introduce rests, short rest during the highly demanding workload, particularly in intensive care units. And we already have reports on cases of violence, psychological, sexual violence, and even physical violence, and in some countries even attacks on healthcare workers because of the COVID-19 response. In addition to that, there is an exposure to a number of chemicals, primarily different disinfectants. Some people use chlorine, and they use inappropriate concentration of chlorine, and that is causing both respiratory damage and skin damage. We're also aware of the skin damage caused by personal protective equipment, both goggles and to a certain extent respirators. But we also are concerned about the reports for contact dermatitis among health workers who have to use latex gloves. And therefore, I would highly suggest that also nitrile gloves were available in healthcare facilities for those who are experiencing latex allergy. It is also important to specify measures for the return to working criteria for the return to work. I see different countries are using also different measures. And now with the country response plans, we started seeing examples of countries developing standard operating procedures for protection of health workers and responders that cover the responsibilities of the managers, the responsibilities and rights of workers, but also cover the need for health surveillance of health workers and responders before the deployment, with training, with awareness raising, with building some minimum set of skills for protecting themselves and for helping their colleagues. Also, during the deployment, the health surveillance is extremely important, and the reporting of injuries and accidental exposure to body fluids, blood, and respiratory secretions, and violence, and observing also the specific rules in the particular health facility of deployment. And after deployment, debriefing of medical and psychological debriefing, and then reporting all cases of acute respiratory infection caused by COVID to the National Funds for Compensation of Occupational Diseases and Injuries. All cases among healthcare workers should be reported to the National Compensation for Occupational Diseases, including also post-traumatic stress disorder. Thank you.
Thank you so much, Ivan, for that. And we would like to just take a few comments now for our guests who presented. So there are comments coming through or questions coming through on the chat and on the Q&A. If possible, you can put your questions into the Q&A facility, because it means then that the panelists have access to them. It's easier to address them in the Q&A facility rather than the chat. They can get a little bit lost. So we'll try and run through a number of questions and do the ones specific, first of all, to the South Africa and the Netherlands presentation. So we have a question from Anita asking, are there numbers of COVID-19 cases among frontline personnel in the Netherlands or other countries? But of course, Anne or Pauline, if you could answer that with regards to the Netherlands.
Yeah, well, we cannot answer this for the whole country, but in our setting in Utrecht, so we're not in the heart of the epidemic, less than 10% of employees with symptoms have COVID-19. So we do see a lot of circulation of, because it's still quite cold in the Netherlands, so we have influenza and other viruses circulating. And that's the good thing, because then people with minor complaints can actually come back to work if they're COVID-19. They do get the advice that if they become more ill, they should be tested again. And we have not seen at this case in our setting circulation among healthcare workers in the hospital. If you go to the more of the heart of the epidemic, there's a higher percentage of employees infected. I'm looking at Pauline, do you know the number?
No, not exactly, but I think in the first weeks it was about 3%. But now they managed to downscale the percentage, so it's less now. And surprisingly, one of the first patients who was not acknowledged as being COVID positive and had been on an ICU ward for an entire week without measures, they looked at all the personnel that had been involved, and not one of them became positive or developed symptoms. So
the Netherlands is pretty strong in its isolation measures. That's something we're known for in the world, and people are really used to many of the measures that actually are also now part of the COVID response. So in that way, I think we have a little bit of advantage here. And also we have in the heart of the epidemic, there has been done some sequencing. And actually you see that the healthcare workers who are infected actually very closely, their viruses are very closely related to community outbreaks and not to hospital transmission, as far as you can judge, of course.
Thank you. Professor Musa, do you, is this something that South Africa is tracking, the number of infections in health workers?
At the moment, I think there's not a formal process, but in Johannesburg, we hope to be able to pick that up with a tool that we're using for patients, patient monitoring in primary care. But no, it's not yet something that I think is being looked at. I think it's very important and it's something we should advocate for.
Thank you. We have a question about the self-monitoring app. Perhaps, Professor Musa, you can comment on whether this would be something that South Africa would like to develop, and would it be helpful in that setting?
I think it could be. I just see that it's in Dutch and not in English. So if it were in English, I guess it'd be very helpful. And I guess it's whether the Netherlands authorities allow it to be used and beyond. But I think it's useful if it's in English.
As well, this week, WHO will be launching the My Health application that will that is intended for the general public to provide information to them. So when that comes out, we'll also make that announcement to this group, and that may be something that can be adapted to national context, promoted in national context.
Will it be in different languages, Catherine?
Yes, it will, and I believe it already is in
multiple
8. I'll double check on that because I'm just learning more about it, but it does. Dutch is a nice challenge, but of course what's interesting is that Afrikaans and Dutch are related. But
no, I agree. But it's
enough.
not the whole population.
But I'm not going to get into that. I am not getting into the Afrikaans Dutch discussion. Sorry about that.
Of course, it'll be understandable, but just not for the large numbers that would be. Perhaps I can just respond quickly. I think I've written some answers, but it'd be worth just noting for the others who haven't noticed it. I think the question of why we see such low numbers of cases and even mortality is something we're finding very interesting. I think this says number of cases and about testing. I think the testing capacity is limited. I know in South Africa there's a constraint on case definition testing because of the case, the number of tests available. They've been very strict about the case definition. I think that's being loosened up now. I think the transmission, in fact, one of the questions, I'm not sure where they disappeared, is we actually were asked the question, why are we seeing such low mortalities? And it actually crossed our heads, just this in a few days, that perhaps it's a lot of the antiretrovirals, perhaps it's also chloroquine being used as an anti-malarial in parts of Africa. These are possible answers for why it's not moving along as quickly as in other parts. But I think that kind of statement can only be done, can be sort of talked of after, you know, a couple of months and seeing the results. So yeah, I just thought I'd comment on those two.
Thank you very much. Rosamund.
Yes, I don't want to be the harbinger of bad news, but I agree, Shabir, with your statement that it would be difficult to assess the case fatality ratio or the incidence of cases at this early stage. South Africa is definitely ahead of many of the other countries in the African region in terms of the onset of the outbreak. But nonetheless, there are other factors that have already been demonstrated in other situations. So for example, Iran and Italy, they were taken by surprise and they already had large numbers of pneumonia cases very early on with explosive transmission. And that's not the situation here. So the countries that are now coming on board, if I can use such an expression, are countries that have had advance notice and warning and time to put systems in place and to detect early and to look for clinical signs and symptoms. So maybe some of those measures are helping to slow things down already in this early stage. But the other factor that I just wanted to mention and hope that it doesn't come true is that we know from other outbreaks elsewhere that young people do become very ill, not in the same numbers, not in the same proportions, but young people who do become ill do so later. They take longer to become very ill. They spend longer in hospital, and those few that do go on to die do take longer to do that. So that for most of the population, what we're seeing now is the result of infections that took place 2 weeks ago. But perhaps for younger people, it takes longer to actually see the effects of the infections because of the amount of time they take to progress to more serious illness and hospitalization. So I just want to add that, Shabir, to agree with you that it's too early to make those kind of statements right now in a situation where many African countries have much younger populations, but other comorbidities that we don't know yet how they're going to interact, including malaria, HIV, TB, and so on.
Thanks.
Thanks, Rosamund. There's a question from Christiane about the types of, it's a question, sorry, for the Netherlands, and regarding the rapid recruitment, are those temporary jobs and what regulations are in place for volunteers in terms of their protection and deployment? So a workforce question.
Of course, as medical doctors, we're not really specialized in this, but from the crisis team, what we have learned is actually the process is much quicker. But we try at this stage, we still keep on qualifications as usual. And since we generally have a shortage of medical employees in the hospital, especially nurses, we hope that we can hold on to many of those people actually for the future. We also have a lot of medical volunteers, which are mainly medical students, and they will of course go back to university, but they're paid for and have the same protection as anybody else who is employed in the hospital.
And also what we see is that nurses that have been recently retired, they volunteer, so that's a good thing.
Yeah, there's actually a national, in the Netherlands, all the healthcare workers are registered in National Registry. The National Registry has decided that anybody who has retired in the last X years is allowed to come back, and has also indicated what kind of training there will be needed to have those people back in the process. So only people who are out of the register because they have been malpractice or so are not allowed to come back. But people who are retired are allowed to come back. So there are agreements on that.
Thank you very much. I also would find it interesting if you could comment on the restriction policies, because I think you mentioned, did you call it intelligent restriction, the way that the Netherlands has not gone into a complete sort of closure of many places, but done it in a staggered way? That would be interesting just to hear if you have some of the rationale behind that.
Actually, our Prime Minister called it intelligent. We feel it's a little bit bold to say that. It's just an approach that really fits well in our country and our way of living. I think that's for each country different. What we actually realized is that complete lockdown in such a highly densified country is really very difficult to do, because then you would really close down the whole country. I don't know, Pauline, if you want to add something to this.
Yes, I think that with the intelligent type of lockdown, where people can go out for shopping, but the shopping is regulated, so no more than X people can enter the shop. There needs to be 1.5 meter distance between them. There's like a hand cleaning available there. So what you see, it's regulated. So you allow people to go out, you allow them to go shopping, but also to take a walk with not more than 2 or 3 people from one household, and etc. This will increase the adherence.
Thank you. I believe we're well over time now, and I understand very well that people are extremely busy. So I think we're probably going to have to bring it to an end. We do have the recording, which we will be able to share. I'd just like to say a huge thank you to Anne and Pauline and Professor Musa for coming on the call and for sharing their experiences and answering questions. I'd like to just open up to anybody who has a last comment. Professor Shabir, would you like to say something?
No, I think, yeah, just briefly say thank you all very much for sharing. I think it's really good. Perhaps you can use the opportunity to mention the Friday meeting, Sarah, and all of you keep safe, go well.
Thank you very much. Yes, so the meeting that we refer to is a meeting on Friday afternoon, and it's specifically for the African context that we will be co-hosting with Wonka Africa and Afro PHC, so Afro Public Health, Primary Health Care, sorry. And if you are interested in attending that, please do let me know and I can add you to the distribution list.
The last comment, I think the Netherlands is of course one of the richest countries in the world. So we do realize that many of the things that we have done are not possible elsewhere. But anybody who would like, and most of our documents are of course in Dutch, but especially for South Africa, maybe people can read some of our protocols. If you need anything, please let us know. We know the situation is different, but some things may be helpful still in other settings as well.
Thank you so much for this offer. Anybody else would like to, from the panel, who would like to say a last word? Otherwise, we can end it here. No. Okay, thank you so much. And I wish everybody a lovely rest of the day. And thank you to all who are working so hard at this time. We really, we're with you on that. Take care, everybody.